Okay, well, thanks for inviting me to say a few words about this study. Obviously, it's been quite a big team effort. There's been lots of other HaemSTAR members that have been very involved. Tom Bull and Pip are the two people that I've worked with most closely. And it's obviously been a huge effort to get the data in from so many sites. So I'll quickly whiz through a few of the key points that we found. This, as most of you will probably be aware, we did manage to get an abstract at ASH for the, sorry, it's on a timer. We did manage to get it accepted at ASH in December. And these are a few of the slides that were included. As you will all know, the background to this is that acute TTP is one of our emergencies in hematology and obviously gets the adrenaline going. Yes, so as I was saying, obviously TTP is one of the emergencies, and there's been a big drive in the recent years to try and improve the national services. So Tina Dutt and Marie Scully have been particularly vocal in trying to get a national service up and running, where we've got centralized hubs where all patients will be expedited admissions from the regional hospitals to try and improve the speed to starting plasma exchange primarily, with the ultimate goal of improving the outcomes of these patients. We know from previous studies that approximately 50% of TTP deaths appear to happen in the early stages of presentation within the first 24 hours. So we feel that that is the key time period. And also that, that plasma exchange is proven to be of particular importance and is the only treatment to date that has shown overall survival benefit. The potential problems with this is that TTP is exceptionally rare. We found that in our study, given that we had 80 centers involved, that we only got data on about 250 patients over a 5-year period. So it highlights just how rare it is, which makes it difficult to come up with a unified national patient pathway. And obviously access to plasma exchange is very limited, with most UK centres having to transfer to a tertiary site, which is an obvious barrier to getting treatment up and running. So our study essentially was to assess the early management of acute TTP in UK hospitals. We tried to measure it against standards set out in the BSH guideline from 2012, and it was basically a retrospective review where lots of trainees from across the country very diligently went through hospital notes and blood tests to try and tease out what had happened with each new TTP diagnosis in the hours leading up to the diagnosis and initiation of therapy. So it was conducted by HaemSTAR, and there was fantastic uptake throughout the whole network. I think with every region in the network contributing data at some level. So thank you very much for everyone who was involved in that. The eligibility, we were looking solely at adults, patients that presented within the 5-year gap between 2014 and 2019. And it was only in first diagnosis of acute TTP that had to be confirmed by an Adams 13 level of less than 10%. This is kind of the map of how the data was collected. As I said, we managed to open it in 80 hospitals, and it primarily all that data was collected within an 8-week period at the end of 2019. Once we'd done that, there was quite a bit of editing that was required as myself, Tom, and Pip went through the data to try and work out if there were any errors that needed to be questioned. And it did take a while for us to do that process. But we've managed to get some reasonable results. So this was what we presented at ASH. So of the 250 patients that we got data on, unfortunately only 148 had complete data. So one of the issues being a lot of these patients were transferred between sites, and we only had data from normally the receiving hospital, the tertiary site. So it was 100 patients. We couldn't use their data. What we found was that plasma exchange with it from basically time of admission, roughly a quarter were getting plasma exchange within 8 hours, and by 24 hours that had gone up to 61%. When we looked at factors that would dictate the speed of treatment initiation, we found that age was quite a big contributor. So older patients were much less likely to receive treatment early. You can see at 24 hours, those over 60, only a third had received treatment compared to 70% in those less than 60. The site of plasma exchange was an interesting one to look at, and unsurprisingly, if you have it on site at 8 hours, you were much more likely to have received the treatment, with 42% compared to 10%. But what was actually quite interesting was that by 24 hours, the benefit of having on-site plasma exchange had mainly gone away, and there was no significant difference. So roughly 2/3 of patients by that stage had received plasma exchange regardless of where they presented. There was a slight difference if you had plasma exchange on site, but it wasn't a significant one. And then the other things that were significant in predicting early treatment were the blood parameters. So obviously patients with more severe anemia, thrombocytopenia, and presence of fragments being reported were unsurprisingly more likely to have early initiation of treatment. You can see that there was significant difference for anemia and also for the low platelet count. What was interesting was that 16% of patients didn't have any fragments reported on their admission blood film. We didn't work out if those patients, how many of them went on to develop fragments during the inpatient stay. And certainly there were a few that hadn't had any blood film done at all. And that had, those patients without fragments had obviously a much slower process before they received their treatment. The troponins were generally checked, but interestingly, having a raised troponin didn't seem to change the likelihood of a patient starting plasma exchange early. You can see that there's similar results, whether it was raised or not. I'm hypothesizing a reason for this. I assume that there is obviously diagnostic uncertainty in a patient who presents with a raised troponin, and TTP won't be the first thing that people are thinking of. Interestingly, the presence of CNS symptoms also wasn't associated with early treatment initiation. And in fact, there was a slight trend for earlier initiation where patients didn't have CNS symptoms. And at the 24-hour mark, again, it was almost identical. And again, hypothesizing that this would relate to patients who were diagnostically challenging, presenting more as a stroke. And then just to kind of illustrate these trends, I've got a couple of Kaplan plots. So these show time to treatment initiation. The box A shows the effect of having plasma exchange on site. And you can see there's an obvious benefit. The median time to plasma exchange was 10 hours compared to 21 hours. But as time goes on, that benefit seems to go away at about 24-hour mark, when there is still a significant proportion of patients that haven't received a plasma exchange. And presumably in these patients, it isn't access to plasma exchange. That is the issue, and it's more likely that it's delayed diagnosis. And then to illustrate the problems of diagnosis, if you don't have typical blood picture, you can see that if you haven't got fragments, unsurprisingly, even at 48 hours after admission, the majority of patients haven't received plasma exchange. And in fact, the median time for this group was 110 hours. Which is perhaps understandable. It kind of shows you how important that blood film is. A few other interesting points from our results. We did show that there was a trend to improved early initiation of treatment in the later years that we looked at. So from 2017 to 2019, there did seem to be an improvement in our services, which is perhaps being as a result of a national push to initiate treatment sooner and to improve our treatment pathways, which hopefully continues to this day. It does show also that although there was an improvement at 8 hours, there wasn't an improvement at 24 hours, which again suggests the issue there is a significant cohort who are not being diagnosed early. At 30-day mortality was monitored, and the total mortality was 12%, which is more or less in keeping with other real-world data. Of those, 6 of them died before plasma exchange was able to start. And interestingly, of 13 who did receive plasma exchange, 6 of them hadn't had plasma exchange within 24 hours of admission, suggesting that there was a delay in treatment initiation, which may obviously have implications in their outcome. And these patients, we feel, need further investigation. So the main points from our study was that overall compliance was pretty good with national guidelines. And I think the goals in the guidelines say to start within 8 hours of diagnosis. It's quite hard to make a direct comparison because we weren't measuring the same thing, but from within 8 hours of admission, I think the figure that we showed in the later cohort, which was about a third receiving treatment, is a good effort. We did show that local availability does affect ability to deliver early, but reassuringly, by 24 hours, this benefit had gone away, and meaning that patients from regional hospitals were starting treatment at a reasonable time once the diagnosis had been made. I think one of the key findings is that delayed diagnosis appears to be a major issue, and in many of these patients, it's probably that they're presenting in a more indolent way with atypical blood parameters that make early diagnosis very difficult. However, there is a third cohort that were not receiving plasma exchange within 24 hours of admission that did have typical blood parameters, including fragments and thrombocytopenia, and they comprised about 20% of all patients. And they're the area that I think is the potential for improvement. If we're going to repeat this audit in 10 years, the hope is that we're going to improve our pickup rate. And that may be dependent on making sure there's good communication and diagnosis between the hematology clinicians and those working in the laboratory. Okay, and so just to update you on where we're at, obviously we've managed to get the abstract at ASH. We've also submitted one to BSH, the virtual BSH this year, and we're in the process of starting writing up a manuscript, which we hope to submit by June this year. And there are a few extra questions about the results that I think we want to look into more detail, particularly looking at explaining a bit more why certain patients seem to be presenting with typical blood results, but are still having delay. And also, we would like to look into more detail as to why some patients were dying with delayed treatment initiation, and if there are any lessons that could be learned from those.